This film looks at processes for transferring patients with acute respiratory failure who may be suitable for extracorporeal membrane oxygenation, or ECMO. ECMO is a national service and there are 5 centres in England. Each centre covers a defined geographical area to ensure that any patients requiring these services are able to access them. Wythenshawe in Manchester covers the north of England. Glenfield in Leicester provides for the Midlands. Papworth Hospital provides for East England. Guy's and Tommy's provides for the South East. And the Royal Brompton in Harefield provides for the South West. All of the ECMO units will care for patients from any network depending on demands and capacity. Any hospital looking at referring a patient for ECMO should contact their local ECMO centre in the first instance. The North West London Critical Care Network's local ECMO service is provided by the Brompton and Harefield. Dr. Anthony Bastin from the Royal Brompton will now take us through the referral and transfer processes so that you know what to do if you have a patient that might require ECMO.
Our service is set up to offer a range of assistance from specialist critical care advice and imaging reviews to on-site assessment and retrieval and the use of advanced respiratory therapies, for example ECMO. We also have the option of thoracic surgical input, specialist respiratory medical input such as interstitial lung disease and infection, and weaning from mechanical ventilation. We offer a 24/7 consultant-delivered advice and retrieval service, including the use of mobile ECMO when required. We are happy to discuss any patients with severe acute respiratory failure who you think might benefit from our service. In particular, this includes patients with potentially reversible disease associated with severe hypoxemia and/or hypercapnic acidosis, despite maximal conventional management. We appreciate that referring centres have different experience of looking after such patients and different access to advanced therapies, including prone positioning. However, we encourage early discussion of these patients as the potential benefit of advanced therapies such as ECMO diminishes with time. You can contact us by phoning our dedicated ECMO referral number and you will be connected to the duty ECMO consultant. Okay. Yep, so tell me a few more details. We will ask you many detailed questions about your patient and their management, and we would ask that you have to hand the relevant results and information at the time of making the referral. For guidance, a copy of our referral form can be found on our internet page. There are few contraindications to ECMO, for example, recent intracranial bleeding or a contraindication to giving heparin. But we would encourage discussion if your patient is potentially suitable. If retrieval for consideration of ECMO is not required following the first discussion, we will offer to maintain contact with you over the coming days and weeks. Of all the referrals we receive, we accept about half for retrieval and consideration of ECMO. Once we accept a referral for retrieval and consideration of ECMO, we send a team from the Royal Brompton Hospital. The team includes a critical care consultant, perfusionist and an intensive care trainee, nurse or assistant. We bring all the necessary equipment with us in order to conduct the retrieval, including a specialist transfer trolley, ventilator, monitoring and infusion pumps, and all the necessary equipment to provide mobile ECMO if required. There are several things that we will ask from the referring hospital. We ask that the family or next of kin are available so that we can discuss the proposed management plan. We will also require a copy of the hospital notes and a copy of the imaging. If we're considering initiating ECMO in the referring hospital, we will ask for a theatre or interventional radiology suite with a C-arm for fluoroscopic imaging, along with a theatre team and a radiographer capable of operating the C-arm. We will need an ultrasound machine for vascular access, 2 units of cross-matched blood, and staff familiar with the environment and able to assist in transferring the patient from the intensive care unit to the operating theatre or radiology suite. When we arrive in the referring hospital, we spend approximately 15 to 20 minutes assessing the patient, including examination, review of the charts and blood results, radiology review, and discussing with the referring team, including the consultant and nursing staff. We will also spend some time with the family to provide appropriate explanation. A copy of our patient information leaflet is available on our internet page. If mobile ECMO is required, the patient will need to be transferred to the operating theatre. For stability, it is usually possible to keep the patient on the ICU ventilator for transfer to theatre. Once in theatre, we will position, clean, prepare and drape the patient. Usually, access is required for ECMO via the right internal jugular vein, though sometimes it is via the femoral veins. Cannulation for ECMO is done using a percutaneous Seldinger technique with fluoroscopic imaging of the guide wire. Once the patient is cannulated, the patient is then connected to the ECMO circuit supervised by the perfusionist. After a period of stability, the patient is moved onto the ECMO transport trolley. This requires transfer of ventilation, infusions, monitoring and ECMO circuit. We will arrange transfer back to the Royal Brompton Hospital.
As you load the trolley onto the ambulance tail lift, be careful not to catch cables or tubing. As the ECMO trolley is slightly longer than normal, it will not fit onto the tail lift until the flap at the head end of the tail lift is flattened. The tail lift is then lifted in the normal manner. Once the tail lift is level with the ambulance, make sure that staff are ready for the trolley to be moved into the vehicle. Due to the large volume of equipment, tubing and cables, each member of the team should confirm that they are ready to move. Then, slowly move the trolley into the vehicle and ensure it is locked into position. The electrical equipment on the trolley needs to be plugged into the ambulance mains inverter.
So, Alison, can you turn the inverter on, please?
One of the crew should press the inverter button located in the saloon electrical control panel. Ensure that the socket being used is switched on and receiving power.
Okay, power on.
This should be supervised by the team leader and confirmed out loud. Oxygen needs to be connected to the ambulance supply using the Schrader valve. Again, this should be supervised by the team leader and confirmed out loud. Equipment should be stowed securely using appropriate restraints.
Unfortunately, it's not possible for the family to travel with the patient due to the space required for equipment and staff. Although initiating ECMO takes 30 to 60 minutes, the whole process from arrival of the ECMO team to departure typically takes several hours. Once we have arrived at the Royal Brompton Hospital and the patient is stable after handover, we will contact the family to inform them of our safe arrival. If the patient improves and extracorporeal support is no longer required, we will typically continue to look after the patient for several days until clinical improvement is confirmed and respiratory weaning is established. At this stage, we will contact the referring hospital to discuss repatriation for ongoing care and rehabilitation locally. We would ask that referring hospitals make every effort to facilitate repatriation locally, either to the referring hospital or within the referring critical care network, in order to allow beds to be made available for the continued running of our service. We will remain in periodic contact with the referring hospital to offer advice where requested, to track progress, and to offer follow-up in our critical care outpatient clinic after hospital discharge. All the information about the Royal Brompton's severe acute respiratory failure and ECMO service can be found on our website.